1880, the American Psychiatric Association added a new diagnosis to the third edition of the Diagnostic and Statistical Manual: post-traumatic stress disorder. It was not a new condition. The symptoms had been documented for centuries under different names: soldier's heart after the Civil War, shell shock after the First World War, and combat fatigue after the Second War. What was new was the formal recognition that traumatic events could produce lasting psychological consequences, and that those consequences were not a sign of weakness, moral failure, or inadequate character. They were predictable human responses to experiences that exceeded the nervous system's capacity to process and integrate. The diagnosis almost didn't happen. There was significant resistance within the psychiatric community. Some argued that formalizing trauma as a diagnosis would medicalize normal responses to difficult events. Others were uncomfortable with the political implications. The Vietnam veterans whose experiences drove much of their early clinical literature were returning from an unpopular war, and acknowledging the psychological cost of that war was itself a political act. But the advocates persisted. Psychiatrists like Chaim Shatan and Robert J. Lifton, researchers who had documented the same cluster of symptoms: intrusive experiencing avoidant hyperarousal across combat veterans, Holocaust survivors, and rape survivors. The evidence was consistent enough and the suffering significant enough that the diagnosis was included. The inclusion changed everything. It gave survivors language, it gave clinicians framework, it gave researchers a target, and it opened conversations about trauma that has expanded continuously in 40 plus years since into attachment theory, neuroscience, somatic approaches, complex trauma, and the recognition that trauma is not a rare extreme experience, but one that many of us see commonly and is in every mental health setting around the world. Today, we're going to teach you the framework, and we're going to make sure that you're ready to use it on your exam and in the room. Welcome to Leicester Lifeline, the podcast that helps you build the clinical knowledge and confidence you need to pass the exams and grow as a clinician. I'm Matt, and today we're covering trauma and crisis, one of the more significant areas I see a lot of with the people I work with. Trauma is one of those things that kind of underlies a lot of the work that we are going to be doing, that you're going to be doing as clinicians. I'm glad and excited about this episode. But before we get into the content, if this is your first episode, welcome. Go to LeicesterLifeline.com and download the free study roadmap PDF before you do anything else. It's a complete 12-domain NCE exam prep guide. Even if you're not taking the NCE, this is a great guide that just gives you a bunch of different information around the different topic areas and can really support you in your studying. But this is completely free. You'll also be able to sign up for the newsletter through that, another free thing that I do each week. It's a great way to get a deep dive into the topics that we cover in the podcast. Again, these are both available through LeicesterLifeline.com, which is also where you can find the link to check out my online community that I offer individuals that are looking for a place to get community and get some support when they take the test. There's downloadables there. I do kind of a study hall / coaching session each week on Fridays. Just a really great way to add a little extra to the work that you're already doing with studying. I don't say this enough, but if you like what you're hearing today, please pass this podcast along to other people. If anybody else can benefit from what we're talking about here, I want them to. And, this is a community that I'm hoping to build just around clinicians and the work that we do. All right, let's get into some news. A recent MedCity News piece published this week highlights a core finding from the ACA study research. The more adverse childhood experiences an adult reported, the greater their probability of developing behavioral health challenges like depression, anxiety, and PTSD. But the data didn't stop at mental health. The same dose-response relationship extends to physical health conditions, including cardiovascular disease, stroke, heart disease, diabetes, and obesity. Reporting 6 or more adverse childhood experiences was associated with a reduction in life expectancy as much as 20 years. Here's why this matters beyond the statistics. Trauma is not a mental health specialty. It is a foundational public health issue that touches every clinical population in every setting. The client presents with chronic pain, adolescents with conduct disorder, the adults with treatment-resistant depression. All of them are carrying an ACE history that is driving their presentation in ways that won't be addressed if you don't ask. Trauma-informed care starts with knowing what to look for and where to look. I can't emphasize this enough. This study, kind of what came out with it, we look and we talk about things like mind body. But if you've read The Body Keeps the Score, that book exemplifies a lot of what we're talking about here. Trauma has a way of kind of getting in there and, leading to a lot of other things. I mean, the way that people deal with the trauma that they experienced, things like overeating or whatever, tends to impact the body in a negative way. So cannot say this enough. We all need to be trauma-informed therapists. Next up in the news, Flourish Health, a mental health provider for young people with serious complex needs that traditional care models cannot effectively support, announced a $46 million in total funding this week with the capital supporting national expansion of their in-home psychiatric-led crisis care model. Worth knowing about as you enter the field, the crisis care gap for adolescents, the space between outpatient therapy and inpatient hospitalization, is one of the most significant unmet needs in mental health. Intensive in-home models are one of the most promising approaches to bridging the gap. You will work alongside these systems as a pre-licensed and licensed therapist. So understanding that continuum of crisis care is just an essential part of your job. All right, let's get into some of the core concepts today. First up, PTSD. Post-traumatic stress disorder in the DSM-5 requires exposure to actual threatened death, serious injury, or sexual violence through direct experience, witnessing in-person learning it happened to a close family member or friend, or repeated extreme exposure to adverse details of traumatic events. Following the traumatic event, the person must experience symptoms across 4 clusters. So let's talk about these clusters. Cluster A, intrusion symptoms. One of the more required clusters. So this would be like recurrent, involuntary, intrusive, distressing memories of the event, recurrent, distressing dreams are related to the event, dissociative reactions, flashbacks in which the person feels or acts as if the traumatic event is reoccurring, intense, prolonged psychological distress at exposure to cues that symbolize or resemble the events, or marked physiological reactions to trauma cues. So one of the things, and I want to stop here before we get into the rest of the clusters, but one of the things that is a really, it's hard, it's very difficult within this work, trauma work, is you don't want to re-traumatize individuals. Getting them to describe what happened to them, getting them to describe the trauma that happened to them can be extremely difficult and not something you necessarily want to happen in the first couple of sessions, if at all. Not that you're trying to avoid the situation, but it's something that you need to very much so ease into if the person really wants to talk about it and go through it. But you have to keep these things in mind, that just them talking about it to them could be just like reliving it, and it can bring them back to that space. So it's something that you really have to keep in mind. Cluster B, avoidance. 1 or more is required for this one. So avoidance of distressing memories, thoughts, or feelings about the event. Avoidance of external reminders, people, places, conversation, activities, object, situations that arouse distressing memories. You'll see this a lot in grief. A lot of people, will have a difficult time talking about the person they lost initially, even talking about what happened, and they'll just avoid any reminders of the memories of that individual. Cluster C, negative alterations in cognition and mood. 2 or more are required here. Inability to remember an important aspect of the event, persistent negative beliefs about one's, others, or the world, persistent distorted blame of self or others for the event, persistent negative emotional states, fear, horror, anger, guilt, shame, markedly diminished interest or participation in significant activities, feelings of detachment or estrangement from others, persistent inability to experience positive emotions. You'll see a lot of clustered C with like sexual trauma that people experience. So they get to this place where, sexuality, things like that, become really difficult for them to even consider or believe. And they have negative beliefs about sex because of the trauma that they experienced from this. Cluster C, alterations in arousal and reactivity. 2 or more required here. Irritable behavior and angry outbursts, reckless or self-destructive type of behavior, hypervigilance, exaggerated startle responses, problems with concentrations, sleep disturbances. The interesting thing about trauma is people develop these things as they're working through the traumatic events for themselves. They're doing their best based on the experience that they've had, the history, their age, their maturity. They're trying to work through what has happened to them, what they've experienced, what they've seen somebody else experience. And this is the best way they can do it a lot of the times. A lot of the symptoms that we end up seeing as clinicians are just the person trying to work through what has happened to them, right? Things like drug use, again, overeating, activities or behavior that are seemingly out of the ordinary. That is them oftentimes just trying to work through what has happened. So, all of these things need to be kept in mind and need to be considered when working with somebody that has experienced trauma. Some specifiers notes that are worth knowing for the test. With dissociative symptoms, things like depersonalization or derealization, with delayed expression, the full criteria not met until at least 6 months after the event. Okay, just wanted to add those in there. Let's go into a different domain altogether. We're going to go into acute stress disorder. So acute stress disorder shares the same traumatic exposure requirements as PTSD, but differs in duration and symptom clustering. So duration for acute stress disorder is going to be 3 days to 1 month following the traumatic event. This is one of those things that the timing, the duration, I know that can really trip up a lot of people. So, this is the one where I use a lot of mnemonics, or used a lot of mnemonics to try to memorize them. I used rhymes to memorize them. So, whatever system that you are using to kind of help you with the duration. But oftentimes on the test, it'll be kind of some of the differences. And the test do not try to trip you up. So you're not going to see a ton of questions that are just like duration, like what's the duration of this versus what's the durations of this. There's not as many of those types of questions on the test. Symptoms requirement for acute stress disorder: 9 or more symptoms from 5 categories: intrusion, negative mood, disassociation, avoidance, and arousal. The critical exam distinction between ASD and PTSD: acute stress disorder symptoms present between 3 days and 1 month for post trauma. So between 3 days and 1 month post trauma. With PTSD, symptoms persist beyond 1 month post trauma. Okay, so acute stress disorder, ASD, is often, but not always, a precursor to PTSD. So somebody might experience the ASD kind of in the moment or right after the moment, and then eventually, as time goes on, it evolves into PTSD. And PTSD can develop without the initial ASD presentation, okay? The dissociative symptoms in ASD are more prominent than they are with PTSD. So more prominent like depersonalization, derealization, dissociative amnesia. So again, like because this is happening so soon, these things are going to be more prominent as our traumatized brains try to figure out what has just happened. And it's kind of grasping for straws. And this is what you're going to see. All right. Let's get into the next domain here. So crisis intervention. A crisis is a time-limited period of psychological disequilibrium in which a person's usual coping mechanisms are insufficient to manage the current stressor. This is a big piece. I cannot tell you how many times over the years, and this is something that I see consistently. I've seen consistently. Trauma for one person may not be as traumatic for another, and vice versa. So, I've had people that have felt traumatized by the fighting between their parents when they were kids, and, versus somebody that has been traumatized by some horrible car accident that they had where they lost a friend or something like that, or they lost a family member. One is not necessarily more traumatic to the person, or, as society looks in and says like, oh, this car accident was definitely more traumatic than a person experiencing their parents having a fight when they were 16, let's say. But to that individual, it was, and we have to do that. We can't sit there and assign judgment to like, oh, that's not that traumatic. We have to consider the person and really consider what they're telling us about the trauma that they've experienced. So the ABC model of crisis intervention: A, achievement, contact, establish rapport and communication. The person in crisis needs to feel heard and not alone before any other intervention is possible. B, boil down the problem. Identify the precipitating event. What happened? What changed? What pushed the person past their coping capacity? One specific identifiable event almost always underlies a crisis. So finding it and focusing on the intervention. And then C, cope. Help the person identify and mobilize coping resources. What has helped in the past? Who is available? What immediate steps can restore a minimum level of functioning? So and then we also have Robert's 7 stages of crisis intervention, which is a bit more of a detailed model. So stage 1, plan and conduct a thorough biopsychosocial assessment, including lethality assessment. Stage 2, make psychological contact and establish rapport. Stage 3, identify dimensions of the presenting problem. Stage 4, explore feelings and emotions. Stage 5, generate and explore alternatives. Stage 6, develop and formulate an action plan. And then stage 7, we're doing a follow-up. On the exam, crisis intervention is not therapy, it's stabilization. The goal is not to resolve underlying issues. It is to restore the person to at least the pre-crisis level of functioning and connecting with appropriate support. And attempting to do deep therapeutic work in crisis state is typically makes things worse. So crisis intervention in the moment. And, you can, probably about, when I first came out of school, looked at the Red Cross to sign up as a volunteer for, being a therapist for crisis intervention. And at the time, because I wasn't fully licensed, I wasn't able to move forward with that. It's something that I want to revisit, especially with the fires that we're having in Colorado, being able to come in and support individuals that are struggling with things like that. But it's a really, when we think about giving back to the community and the things that we can do to give back to the community, being with people in moments of crisis, environmental crisis, whatever, it is a needed area. It's something to definitely look into as part of the work that you do. And the approach is completely different. They've actually shown studies where people have used chatbots during crisis and because the chatbot is just so straightforward and whatever, it's not necessarily going into depth. They were extremely helpful. Like, this is a completely different type of therapy. This is a being with somebody in the moment type of therapy, or approach. I shouldn't say therapy, but it is. It's very needed. If it's something that you're interested in, I highly recommend getting into that area. Next up, suicide risk assessment. Suicide risk assessment is one of the most clinically significant skills you will develop as a pre-licensed therapist, and one of the most consistently tested on the licensing exams. Let's build some framework here. Some risk factors, variables associated with increased suicide risk. So this is what you're looking for when somebody comes in for their risk of suicidality. Previous suicide attempts, single strongest predictor of future attempts, access to lethal means, particularly firearms, current psychiatric diagnosis, especially things like depression and bipolar disorder, schizophrenia, substance use disorder, borderline personality disorder. All of those have this tendency to have a significant component around impulsivity. And, it's something that we really need to look for. Hopelessness is also something that's really important. Research by Aaron Beck established that hopelessness as one of the most strongest predictors of suicide, independent of depression severity. Recent significant loss, relationship, employment, financial health, social isolation, families, history of suicide, recent discharge from a psychiatric hospitalization. All of these things are things that we're looking for with suicidality, and kind of keeping in mind within the assessment. Protective factors, variables associated with decreased risk. What is the person's reason for living? Something that I do a lot of the time, especially with adults that have kids, is bring it back to, what will this do to your family? What will this do to your children? And getting them to talk in terms of, their reasons for living. If they can't do it for themselves right now, they need to do it for somebody else. They need to do it for somebody that they love and loves them. Religious and moral beliefs about suicide, strong social support, engagement in treatment, problem-solving abilities, fear of death or dying. These are all things that are associated with decreasing the risk. So let's look at the SAD person scale. This is a mnemonic for clinical assessment. So sex, men statistically are at higher risk for completing suicide than women are. Age, adolescent, young adults, and older adults are at higher risk. So middle-aged adults, not so much. And then depression. Then you go down into the different things like previous attempts, ethanol or substance use, rational thinking, loss, psychosis, social support, things like that. So there are 3 levels of suicide ideation in the assessment. So there's passive ideation, wishes to be dead, not wanting to wake up, wanting life to end, no intent or plan. Active ideation without a plan, thinking about suicide, but not specifically plan. Formulated active ideation with a plan, specific methods, mean, timeline, identified. This is the highest immediate risk. So when they have an active ideation with a plan, like that's when you're really looking to call, get some like crisis intervention, some support for that individual. Lethality assessment. Do you have a plan? What is the plan? Do you have access to the means? What are you thinking of acting? When are you thinking of acting? Have you made preparations? These things can be difficult to ask, but kind of what I said about, things that set people up for potential suicide risk. If you're starting to hear some of these things, we have to go into this lethality assessment. And, it is like, especially first coming into the field, can be kind of an edgy, scary area to start to talk to somebody about. But in the moment, it can be a life-saving conversation to have with somebody. The Columbia Suicide Severity Rating, CSSRS. You may see this on the test. This is the most widely used standardized suicide risk assessment tool. And, you need to know it exists. So that's Columbia Suicide Severity Rating Scale, C-SSRS. So remember, a lot of these things come back to our duty to warn and duty to protect. When a client presents with suicidal ideation, the clinician has the legal and ethical obligation, which varies by state, but it generally includes documentation of the risk assessment. Is there a safety plan? Is there a consultation with a supervisor? We need to document these things. We need to assess for lethality. We need to keep that individual and the other individuals around that person safe. All right, let's get into what trauma might look like if you see it in your office. So a 26-year-old client was involved in a serious car accident 6 weeks ago. He wasn't injured, but witnessed the death of the other driver. Since then, he has been unable to drive, wakes nightly with vivid dreams of the accident, is startled by any sudden sounds, has become withdrawn from friends and family, and describes feeling like a different person. Emotionally numb and unable to feel positive emotions he previously experienced easily. 6 weeks post-trauma. Intrusion symptoms, nightmares, startle response, avoidance, unable to drive, negative alterations in mood and cognition, emotional numbing, withdrawal, sense of a changed self, arousal symptoms, hypervigilance, sleep disturbance. This is duration more than 1 month, full criteria across all 4 clusters. So this is PTSD, right? Not ASD. The window closed at the 1 month mark for the ASD. This is not just a normal stress response. The duration and functional impairment are significant. And again, people can have an accident like this and have the skills in place to deal with something even as horrifying as witnessing somebody else die. But somebody else can carry this with them for a very long time. So, it's very individual. This work is very individual. But treatments tend to be things like trauma-focused CBT, specifically prolonged exposure or cognitive processing therapy. These are kind of like the first lines of defenses. I'm sure you've all heard of EMDR. Has really strong evidence behind it. I know a lot of my friends utilize EMDR. It doesn't do very well in an online format. This is something that you need to go in person for. And then we have pharmacological treatments that we can use as well. But check out The Body Keeps the Score. It's a book I've recommended before. It's one of those books I read semi-regularly. I wouldn't say once a year at this point. But it's just one of those books that helps, keeps me reminded of what I'm working with when somebody is dealing with a lot of trauma. But 3 things to lock in for your exam. Know the duration distinction between ASD and PTSD. 3 days to 1 month equals ASD, more than 1 month PTSD. Know the 4 PTSD symptom clusters by name and content. So intrusion, avoidance, negative alterations in cognitions and mood, alterations in arousal and reactivity. The exam will describe symptoms and ask which clusters they belong to, potentially. 3, suicide risk assessment is clinical judgment, not a checklist. The strongest predictor of future attempts is previous attempts. Hopelessness is also a strong predictor, stronger than depression severity alone. Active ideation with specific plan and access to means is the highest risk clinical picture, and one of the most likely requiring immediate actions. You're going to hit a point, everybody does, in the work that they do, where you're going to have people that have experienced trauma that are suicidal. And you need to have kind of your system in place. I've had to call crisis intervention a handful of times just to make sure that people are safe, and get them into inpatients or get them the support they need. But having that personalized plan that you've created in collaboration with the individuals that you're working with, so there's no surprises. You don't want to send a wellness check out to somebody that, it's just off the cuff. If they're telling you in session that they are worried about tonight, that they're, scared what they might do, that they don't have any support, talking to them about it like, hey, I like, just based on what you've told me, I want to make sure you're okay. And, I'm going to send somebody around for a wellness check. If I don't hear from you, let's say send me like a quick text at whatever time, 5 o'clock or something like that. Or an email or something like that. But you want to make sure they're taken care of. That's an example where you also want to make sure that they're getting like maybe support the next day. So, they're maybe going to be alone for the night, but the next day they have family coming back home or whatever. But you want to make sure that somebody is going to be around them. So having something where there's a wellness check there is going to be important. I cover all this stuff in the, I'll reiterate all this stuff, I should say, in the newsletter. We'll also go a bit deeper and really talk about some of the other things that go along with trauma and suicide risk assessment. How about some multiple choice questions? Question number 1. A 29-year-old client was assaulted 6 weeks ago. Since the assault, she has experienced recurring nightmares about the event. She has avoided the neighborhood where it occurred, feels emotionally numb and detached from people she was previously close to, and is constantly on edge and easily startled. She reports these symptoms began within days of assault and have continued since. According to the DSM-5, which diagnosis best fits this presentation? Is it A, acute stress disorder? Symptoms began within days of the trauma and are consistent with the acute stress response. B, adjustment disorder. The client is having a difficulty adjusting to the stressful life event. C, post-traumatic stress disorder. The symptoms have persisted for more than 1 month across all 4 required clusters. Or D, major depressive disorder. Emotional numbing and withdrawal are depressive symptoms. Answers are going to be C, that's PTSD, folks. The client symptoms have persisted for 6 weeks beyond the 1 month threshold that distinguishes PTSD from acute stress disorder. The presentation includes symptoms across all 4 required clusters: intrusion, nightmares, avoidance, avoiding the neighborhood, negative alterations in cognition and mood, emotional numbing and detachment, and alterations in arousal and reactivity, hypervigilance, exaggerated startle response. Question number 2. A client presents to a community mental health center in acute distress following the sudden loss of her job. She describes feeling overwhelmed, unable to think clearly, and says she doesn't know what to do. She has no history of mental illness, no suicidal ideation, and her distress appears directly related to the job loss. According to crisis intervention principles, which of the following best describes the primary goal of the clinical initial response? Is it A, conduct a comprehensive psychiatric evaluation to rule out underlying mental health issues? B, help the client develop insight into the underlying psychological issues driving her distress? C, establish rapport, identify the pre-capitulating event, and help the client mobilize coping resources to restore functional stability? Or D, refer the client to a higher level of care given the severity of the acute distress? Answer is going to be C. Crisis intervention is not therapy. It's stabilization. You're just looking to stabilize this individual at this point. Saw so much of this during and little after COVID. So many individuals losing their jobs, getting laid off, and dealing with significant stress in the moment, and just needed a place to talk, a place to get stabilized, a place to just figure out next steps. So, we're using the ABC model for this. That whole achieve contact, establish rapport, boil down the problem, identify the event, and then just helping them cope, helping them get through in the moment. Question number 3. A therapist is conducting an initial risk assessment with a client who mentions that he has been thinking about suicide. Which of the following pieces of information is the most critical to assessing immediately in order to determine the level of clinical risk? Is it A, the client's family history of suicide and mental illness? B, whether the client has a specific plan and access to the means to carry it out? C, the duration of the client's suicidal ideation in relation to his current diagnosis? Or D, the client's history of previous psychiatric hospitalizations? Answers are going to be B. While all 4 options provide valuable clinical information, the most immediately critical variable in determining current risk levels is specificity of the plan and the access to means. And I know maybe a lot of you kind of looked at A, that family history of suicide as mental illness. Yes, like we said, that is a really important piece here. But the most immediate is whether that client has a specific plan and access to a means to carry it out. All right. Question number 4. A client with a history of 1 previous suicide attempt presents with active suicidal ideation. She reports she has been thinking about taking a lethal dose of her prescription medication. The medication is in her home. She has no specific timeline, but says the thoughts are becoming more frequent and harder to dismiss. She lives alone, has no family in the area. Which of the following most accurately reflects the appropriate clinical risk management for this client? Is it A, schedule a follow-up appointment for next week and ask the client to call if she feels unsafe? B, the previous attempt history is not relevant because she has not made a plan. The risk is moderate and outpatient monitoring is sufficient. C, conduct a thorough safety assessment, develop a collaborative safety plan, including means restriction for medication, contact a supervisor for consultation, and consider whether a higher level of care is indicated. Or D, immediately call 911. Any client with suicidal ideation and previous attempts require emergency hospitalization. Answer is going to be C. The client presents with multiple high-risk features, previous suicidal attempts, the strongest predictor of all of this, active ideation with a partially formed plan, and she's expressed specific method, and she has access to the medication. It's at her home, and then limited social support. She lives alone. So you want to make sure this individual is safe. You want to go over a plan with them, kind of like what I was talking, where it's like, hey, let's talk about this. Let's collaborate on what we can do to make sure that you're going to be safe tonight, and then probably get her in some type of inpatient the next day, if not that evening or something along those lines. But you want to make sure that this individual is safe. There's too many factors here that are pointing to her potentially being able to carry this out. Question number 5. A researcher is studying PTSD treatment outcomes and reports that a client who met full PSD criteria immediately following a trauma no longer meets criteria 6 months later without having received formal treatment. Which of the following most accurately explains this finding within the trauma literature? Is it A, the original PTSD diagnosis was incorrect? Trauma symptoms resolve within days without treatment. B, natural recovery from PTSD is well documented. A significant proportion of individuals who initially meet PTSD criteria show symptoms remission over time without formal intervention. C, the client must have received informal support that constitutes an evidence-based intervention. Or D, the findings indicate that the PTSD criteria are too broad and produce false positive diagnoses. Answer is going to be B. Natural recovery from PTSD is well documented in the trauma literature. A significant proportion of individuals who initially meet PSD criteria, estimates range from 30 to 50% depending on the population and trauma type, show meaningful symptom reduction over time without formal intervention. This is clinically important for 2 reasons. First, it explains why some clients improve with supportive therapy or without treatment at all, or Yes. And then second is it is why a 1 month duration criteria exists to distinguish the normal acute stress response, which often resolves on its own, from the persistent condition that requires intervention. Real quick story, I had somebody come in to my office, and this happened. There's one story that specifically sticks out to me, but this has happened many a times. But this one that I'm thinking of in particular, they came in and they told me this horribly, horribly traumatic history. And, some things that happened to them in their childhood, some real complex trauma, where things had just been done to them and things they experienced and just a lot of pain. Meanwhile, this person had a great life. They were married, had kids, had a really good job. They had done just very well for themselves in their lives. And, when I was talking to them about why they came here, they told me that basically they had told this story to a good friend of theirs that they really had never told this story to. And their friend told them that they should be more traumatized than they actually were. People, this is one of the more amazing things with people is they are really, really resilient. And even some of the most traumatizing, traumatic things, people are able to get through them and figure some stuff out, sometimes even on their own. This individual, this is one of the first times that they had gone to therapy. They said they'd done some brief therapy, right after some of the things were discovered when they were a little bit older. That had been happening to them. They'd done some brief therapy right after, but it wasn't really something they stuck with. But this individual story was a story of survival. This individual story was a story of growth, that they had really figured out on their own. They'd also met some really good people along the way that just gave them some really good support. And, they were able to get through this. So, I wanted to relay that to kind of close out that, this section of the podcast. And that is going to do it for the episode. A couple of things here before you take off. One, know the duration distinction between ASD and PTSD. Just know that. Acute stress disorder is 3 days to 1 month. More than 1 month, PTSD. The timeline is an exam signal. 2, know the 4 PTSD symptom clusters by name. Intrusion, avoidance, navigate alterations in cognition and mood, alterations in arousal and reactivity. The exam describes symptoms and asks which cluster. 3, suicidal risk assessment is clinical judgment, not a checklist. Previous attempts is a strong predictor. Hopelessness predicts risk independence of depression. The reason I keep on saying this is a clinical judgment, this is going to come down to a moment with you knowing the person that is in front of you. To the best of your ability. So, it's going to come down to your judgment to keep this individual as safe as possible. The newsletter this week goes deeper into complex PTSD, trauma-informed care principles, and the ACE study and its clinical implications. Second, before we close out the episode, a few things I don't want to miss. If you don't have If you don't have the free Licensure Lifeline study roadmap yet, go to licensurelifeline.com right now. You can get the roadmap for free and sign up for the newsletter there. This week's newsletter goes just deep into PTSD. Excited about it. I love this area. It is, again, one of those areas that we need to be well informed around. You can also take a look at the community that I've been creating. You can get 2 weeks free, no credit card, nothing, cancel anytime, just to take a look and see if this is something that you want to be a part of. It's $29.95 a month if you decide to move forward with it, and you can cancel anytime. That is going to be it, folks. Thank you for joining me for another episode. Until next time, never stop learning.